Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, we are going to talk with Dawn Park. She launched her career as a cardiac sonographer in Michigan in 2000, following her graduation from the College of West Virginia. While initially focusing on scanning adult patients, she seized the opportunity to learn pediatric echo, discovering her passion for congenital heart disease. In 2009, she transitioned from Children's Hospital, Colorado, as a pediatric and fetal cardiac sonographer. She was also the education coordinator. After 13 years in Colorado, she traded mountains for beaches, enjoying what she calls a very long vacation in Florida. In March of 2024, Dawn joined Nationwide Children's Hospital in Columbus, Ohio, as a pediatric cardiac sonographer educator. She also volunteers with ASE and the Society of Pediatric Echocardiography and the SDMS. Please help me welcome Dawn Park. Please help me welcome Dawn Park, returning back to us to talk to us about red flags in our fetal echo. So welcome, Dawn.
Thank you. It's great to be here again.
Again, I saw part of this presentation at the SDMS, which I can't say enough about. Going to it's a great time to go and to meet other people and get new ideas and different people's perspectives. And I really appreciated Dawn's perspective, being that she's pediatric cardiologist in her specialty, and I'm MFM. So having friends in other modalities really helps me to get better and see things from different perspectives. So thanks for joining again.
And I phone my MFM friends all the time too. So it goes both ways. I tell my patients, I'm like, I don't scan the rest of the baby. I stay in my lane. But then you see some weird things and you're like, what is this? And so
right?
my MFM friends all the time.
So I think this was helpful because, as an MFM sonographer, I think sometimes you put the probe down and you're like, oh, bleepity bleep, there's something going on, right? And where do I start, right? And so I think this was a great presentation just to where do we start?
Yeah.
What do we look for? What kind of, how do you start to kind of pick apart what might really be going on, right?
Yeah, I think for me, the biggest thing that I always tell my sonographer friends is that when the rules are broken, you refer. We want you to refer the patients. We should actually have, when I was in Colorado, a lot of our referrals were all positives. There was a lot of hard stuff because we had amazing MFMs doing the screening echoes. Here, I'm doing a lot of screening echoes, so there are a lot of normals. But when we have rules of how the heart should form and how a heart is normal, and when something is not lining up correctly, it's like, please just refer the patient. I don't care if they're 15 weeks or 38 weeks. You need to refer them, because sometimes even when you guys are suspecting one thing, it might not be that, but it could be something else. And so even though somebody might say aortic stenosis, I'm still going to look at the whole heart and we're going to clear the whole heart, hopefully, or figure out what's going on.
Right. Yeah. One of the frustrations for me as a maternal fetal medicine sonographer is, we've kind of developed this specialty of fetal echo in the course of my career, right?
Yes.
And so it's nice to add like, oh, you have 10 more pictures of the heart to look at, right? But in all reality, it's a subspecialty that we're kind of like cramming into the routine anatomy, right? So
Mm-hmm.
I think, you're right. Always refer. If for any question, right? The bottom line is always refer, right?
Mm-hmm.
But we have to understand, and I tell my patients ahead of time, I'm happy to walk you through and tell you what I'm looking at and different things like that. I do get quiet when I look at the heart. There's lots of parts and pieces to it. I'm not going to sit there and try to explain all those parts and pieces
Yes.
to the patient, but I do want my full focus where I'm not interrupted when I'm looking at the heart.
Yeah, I fully agree with that. I feel like when I do my fetal echoes, I'm fairly quiet unless the family is very chatty. I'll chat with them. I can multitask usually. But a lot of times it is quieter. And again, I'm not going to go through all the parts. If I've got a cardiologist sitting in there, oh yeah, I'll be telling you what parts I'm seeing and
Right.
all of that. But most people don't have the understanding knowledge. When you have patients who are terrified to be there because they had a prior baby with a major congenital heart defect that might have been lethal or, didn't survive. Those ones are a little harder and a little more challenging just because I want to make sure we see everything so well to clear that heart to give them the good news. Unfortunately, we do have some that have repeat issues. So I think it is just important to think through it. I'm thinking through it like when I put the probe down and I'm like, oh my gosh, I don't even know what I'm looking at. You just got to build your house. You just start
Right.
depending on how the baby's laying, but you start putting the pieces of the puzzle together, and then you can start to form your idea of what it is in your head. And I have many cases where I have harder patients to scan. And I was with one of my fellows one time, he was just watching, but we left the room and I was like, okay, so I first thought it was a hypoplast, then I thought it was canal, and then I was questioning a truncus, and now I think it might be a dwarf. Like we went through everything, like the
All
whole
right. I love it.
there's like 5 diagnoses that I had given the baby while I was scanning until the end when I
Right.
got a picture. And you just laugh. Like it's just like, okay, at least my brain is thinking of all these things because of how something might look. So
Yeah, and as a side note, just really quick to mention, it's not a one and done, right? Like, so 20 weeks you could clear and look great, but they're coming back for growth and you're thinking, "Oh, okay, well the heart was cleared earlier and not a big deal if I don't get this exact angle or whatever." It is a big deal. It is a big deal. Like, um quite a few of my colleagues have or our colleagues have picked up pulmonary stenosis later,
yep.
and different, rotations of the heart or sizes of the heart. It can all change, sometimes, most of the time, subtly, you know, but still change, right? And so I almost think that looking at the heart later in pregnancy can almost be a little bit more challenging because it was normal before,
Mhm.
and the changes that are going to happen are probably going to be more subtle, right?
Yeah, and even in late term gestation, there's some things that are different, but it's still normal. So your right heart is going to be bigger than your left heart. Your ductal arch
It's
can
going
be
to
tucked. Yeah, it's going to be real tortuous, and that's okay. But it makes the aortic arch look funny too, or because of how it's twisting and turning, it might make the aortic arch look small when it's not really. But then your right side's dilated. You're like, well, is it dilated because we're due in 2 weeks, or is it dilated because there's a coarct? And so, yeah, lots of different reasons of
yeah.
all the different late term stuff. And I mean, even it's important to bring up like people go to their anatomy scan, can't see the heart, come back in 4 weeks, can't see the heart again. come back in 4 weeks. And so now we're late 20s and it's like, well, you can't see the heart because half of it's missing. And now they're not getting that diagnosis till 12 weeks past when they should have gotten it.
Right.
And so
Right.
those ones are the frustrating ones for me, especially if you live in a state where there's options and the family wants options, and now you're out of the window for options. And, you know, it's our job not to judge our patients, but to support them. And so, for me, not living in Colorado, it's a little bit more challenging because I liked our laws in Colorado.
Which far, if you don't mind sharing, what were the laws in Colorado and how are they different than where you're at now?
So in Colorado, it was like 24 weeks. You could do termination up to. We had there, I don't know if he's there anymore, but there was an individual in Boulder, Colorado, who would do even later term gestational medical terminations. And so we had sent some people to them as well. But there was a couple different places in Denver that would take care of it. And it's not like you walk in and it happens. It's a multiple day process. You have counseling and all of that. And then I went to Florida and they had like a 6-week issue or something
Okay.
insanely ridiculous. And so that was the state of Florida. And then now that I'm at Nationwide, it is, I'm not 100% it's interesting in Colorado. It just seemed to be talked about a little bit more with the families. And of course, our physicians counsel that is an option, but it's not an option I see taken here as much as I did in Colorado.
You're in Ohio now?
I'm in Ohio now, yeah. So I'm not 100% sure. I think I mean, everything's changing right now. It seems like it changed. I thought it's better than Florida. We'll just say that. I know that much. But again, we don't have many patients that choose that. We do have a lot of patients who choose comfort care. So that's another option. Like these patients have to be given all of their options.
Right.
And again,
Absolutely.
we are here to support you, not judge you.
Right.
And so, you know, when I have a sonographer or somebody getting into fetal, that's one of the first things I tell them. And it's like, if you can't support the family and the patient, because you're in there for a long time and they talk after they know a diagnosis, they start talking. And they trust us. And if you can't support any decision, then that is not the spot for you to be a sonographer. I had one time early on in fetal, I think it was a tricuspid atresia. So it was like hypoplastic right. Same diagnosis, 2 patients in a row. So I had one patient say, how can you not do everything you can to give your child life? And they were obviously going to be going down the single ventricle route. I had the next family say, how can you do that to your child? And they went down the comfort care route. And it was like that day was like mind blowing for me because I was like, yeah, I hear you. I hear all of it.
Right.
And you never know how you would act until you get put into that position.
Absolutely. Yeah. I want to say my
Uh,
career
yeah, to
ultrasound
support
has
them.
definitely taught me that, and definitely changed a lot of my perspectives, and beliefs, quite honestly, um, for that reason. Like, holy cow,
Right.
don't know what I'd do if I were in that situation,
Mhm.
and yeah, it's certainly not for me to judge that because
Right.
God knows I would
Mhm.
know what I'd be doing.
And okay, so I just had my Google pull up. Ohio abortion is legal up to 21 weeks, 6 days gestation. So that's better. But even if you're coming in at 20 weeks and then they say come back in a couple weeks, like you're out of your window. So yeah, yep.
Yeah, a lot of states that I've been in as a traveler have been 24. So it's interesting that that's 21 and 6. So that makes a big difference, right? Because
Yeah,
sometimes for our
yeah,
patients who have a larger BMI, we're pushing them out a couple weeks so we can
yeah,
get a better heart or anatomy because of their BMI.
right.
So that really changes the way you manage your patient, right?
Yeah, now abortion is now legal in Florida after 6 weeks of pregnancy. So what is the legal age of abortion? That's the age of the patient. It was like a near ban that went into effect. So it is saying so they did have a 15-week abortion ban. But May 1st, the Florida governor signed into legislature that they outlawed abortions after 6 weeks.
In Florida.
Another reason I was not happy in my position because the laws didn't support the families.
Right.
And, you know, I would hate for something to happen to my daughter, but being a mom and having a daughter, I wasn't going to raise her. I wasn't going to raise her in that environment. And that's my personal opinion and belief in my families. And everyone has their own, and it's totally fine. But I personally struggled with that part as well, to not be able to support our families.
Yeah. Yeah.
So, yeah, yep, times are changing.
Yeah. Yeah. Are they ever? Right?
Yeah. Mm-hmm.
Okay.
Okay.
Well, which makes our job even more important, I think, right? Bringing it back to being able to kind of figure some of this out.
Mhm.
And, I think there's some things in cardiac that have been known to be successful in surgery, right? And to change. And then there's other conditions that are known to not really make successful life. And
Right.
so I think being able to help decipher that rather
Mhm.
quickly is vital to our patients.
Yeah, like today I scanned a patient. We were just clearing the heart, but it was one of the types of dwarfism, like lethal types of dwarfism. And it was just crazy scanning the baby kind of in a sagittal plane, and you see the stomach, and then you just see it like crush and collapse in the chest. I'm like, oh my gosh. And they're gonna probably do comfort care, but because she was farther along in pregnancy too. But it was just like, wow, this like the CT ratio was really high because the chest was so small. Not that the heart was big. It's just the chest ratio was so small. So it was crazy.
Yeah. Yeah. So the other thing I think it's good to mention is that we have multiple eyes looking at a defect, right? And we have multiple, like sometimes we do an MRI, right? After a defect that we see in MFM, or we send them to pediatric cardiology. So at least the patient is hearing it multiple times, and it has a little bit more confidence that
Mhm.
we're providing the best diagnosis for them to make
Right.
educated decision, right? So I think of myself, I'm like, I want to know that, okay, she thought this and she thought this. And if they don't agree, you kind
Hmm.
of, as a patient, are sitting there thinking, well, shit, who do I believe?
Right. Yeah.
Like,
Yeah.
we
Uh,
don't want to tell somebody anything wrong. So I think in MFM, we're careful to really put a diagnosis to it, you know,
yes. I feel
but
like when I have my patients come in from MFM, I say, what did they tell you? And it's kind of like a generic kind of, the left heart was small, the right heart was big. They can't see all the vessels. Like there's, in the referral forms, it says a little bit more, right?
right,
But
right.
what the patient is told, is obviously different. Like we had one that, it was many years ago. It was they said they gave the patient MFM or OB, or somebody gave this patient a diagnosis of aortic stenosis. It was really a truncus arteriosus. I mean,
Yeah.
it was stenotic. I'll give them that.
You were
It's a
partly
pulmonary outflow, 40% outflow. So I mean
right.
that. So yeah, you just never know. But I think it's important to have, I think it's frustrating for me when the family, when the MFM has clearly said there's something wrong with the heart. And they come in and they're so excited to see the baby again, and they think everything's gonna be okay. And it's like, no, it's not, or we had I was like early 30s. They just couldn't see the heart, couldn't see the heart, couldn't see the heart. And it was like a dwarf pulmonary atresia. And this family, I mean, was so upset. Mom walked out. We had to have, like, she, like the doctor said, there's something wrong with the baby's heart. And this is what it is. And the mom walked out of the room. She was so upset. Like they were not expecting that at all. And you just feel so bad for them. And it was an interpreter situation on
Mhm.
everything else. And it's just so hard. Mhm. So
Yeah, and the other thing to keep in mind is like ethnicity of the patients, right? And they're in that ethnicity, there are certain beliefs or religions that are pretty common. And
yes,
so any kind of defect affects that, you know,
yes,
for
yes.
them and their belief system. And so, yeah, back again, we're important. We matter. And the better we get, you know, the better we can give to our patients. So let's start
Interesting.
with
I was going to say, Ohio, I have learned there's a very high population, like a Somalian population, and like a lot of people from Ghana and like West Africa. And it's very interesting. I live in a very diverse neighborhood, and just getting to know my neighbors and understanding their culture is helping me in my job because I have a lot of patients in the same culture. And I think that's also, it makes you a better sonographer too, to understand the cultural beliefs that
yeah,
go along with decision making. So,
right,
yeah.
right.
Okay. Now for the
So
good.
let's start with your lecture that really kind of started with malposition.
Yes. Yeah. Yeah. Yep.
And
So, yeah, cardiac malposition. That's your first red flag when you put that probe down. I feel like when we check what way the baby's laying, we check what side of the body the heart's on, the stomach's on. The next thing is like, okay, what is the position of the heart in the chest? We want it to be levocardia. We want it to be at a cardiac axis of like 45 degrees plus or minus 15 to 20, depending on the book you read. So when you have an axis that is not within that 45 plus or minus, that is a sign that something could be wrong. So like if it's mesocardic, where the apex is pointing like straight forward from the spine, those can have an association with LDTGA, or uh, where you have like ventricular inversion and stuff like that, or congenitally corrected transposition as well. If you have levo-rotation, so it's like over-rotated, it can be common with Epstein's and TETs as well. Like if your axis is like 90 degrees, like something is probably wrong. I've seen cases where they're not, though. I've seen cases where they're totally over-rotated and it's structurally normal. I'm like, good for you guys.
right?
Right.
Imagine that, right?
Right. So yeah, position of the apex of where it is very, very important. And like when you have a diaphragmatic hernia, like say you have a left hernia, the heart is in the right chest because it pushes it over. So we say dextro position, but then we'll go on to describe what way the apex is going. So the cardiac apex would be dextro position, apex to the left. So it's just pushed, it's not flipped.
Correct.
So that's a difference we have. And then,
So
yeah,
20 degrees is a lot,
it is. That's
right?
like plus minus, that's
Yeah,
like 30 degrees.
right,
Yeah.
right. That is
Mhm.
normal, right?
Yeah.
So, I remember first starting out and talking about and studying malposition, and there for a while, I just threw the calipers on every heart all the
Mhm.
time, just so my eyes got used to, yep, that's good. Yep, that's good. So it never hurts to just,
Throw it on there when you're questioning it. And then after time, like I can look at it and tell you whether it's off axis or not. And I don't use the calipers. But I think, especially in the beginning with the newer sonographers or even anybody, you might just question, like throw it on there.
right.
And
Yeah,
if
it's anything.
it's,
Yeah.
64 degrees or 63 degrees, just refer them.
Yeah. Right.
Just refer them. Because we'd rather say, I mean, I had a kid the other day. I was like, I think the heart was fine. I think it was like IVF or something, but I was like, it's a little mesocardic in there. So we reported that, but the heart was fine. So
Yeah.
yeah, shouldn't create any issues though. Um,
Yeah. So then what would be the next thing you would want to look at after you figure out the orientation of the heart? What's the next thing that you kind of start to pull your eyes toward?
The next big thing, I'm going to skip around on my presentation a little bit, that I look at, like I do my situs, and then the next picture I try to get like 95% of the time is a 4-chamber view of the heart. And then after that, it's kind of a free for all based off how the baby's laying. But in my mind, I know the heart's in the left chest. I want to make sure that there's 4 chambers. And so I look, at the 4-chamber view. So one of the things that I look for is looking for a crux. So that is the crux cordis of the heart, which basically crux just is a Latin term that means cross. And so it's basically on the lower backside of the heart where the coronary sulcus and the posterior interventricular sulcus meet, and it creates that cross. And so when we don't have a crux of the heart, it's time for a referral. The chances are good that it's probably some form of an AV canal or AVSD. And there's different types of AVSDs. We have complete, we have partial, we have transitional, we have
Right. It's never straightforward, right?
so yeah, if you're missing a crux and you get dropout in every view, then chances are good it's probably some form of a canal, which goes along with trisomy 21 as well.
Absolutely.
And then from there, after I look at the crux, I'm going to look at my chamber sizes. So those are going to be my big ones that I want to look for. Is the right heart too big? Is the left heart too small? And so remember though, in third trimester, the right heart does get bigger. And that is normal development. And so when we get these late term ones, it's really hard to say, is it just big because we're getting ready to have a baby, or is it big because there's something wrong with the heart? And when we have our right side bigger than our left side in that late trimester or whenever, we want to rule out an aortic coarctation. And so whenever I see right's bigger than left, and it's like not a hypoplast situation, I want to look at that aortic arch. And so it's important to see your aortic arch in multiple planes. You need to see it sagittally. You want to see those head and neck vessels come off the aorta. I want it to be a nice arch. I want it to be a nice candy cane arch. And then in my 3-vessel view, I want to sweep all the way from like my 4-chamber all the way up to the 3-vessel trachea view. I'm going to also make sure I know whether it's a right or a left arch as well. But it's so hard to get these late gestation. I know it is, but it's so important. So when the right heart is bigger than the left, my first things go to coarctation.
Yeah, I had one the other day where the baby was laying in this really cattywampus kind of position. Like I even had trouble getting a really good abdominal circumference, right? And I take my case in and I'm showing the doctor and I'm like, yeah, I don't know. What do you think about this heart? Because I had put all these measurements on the heart and I was doing all this thing and I'm like, I don't know. And right away he looks at it like, Deb, you're kind of off axis. And I'm like, yeah, but am I really, like,
Yeah,
and he went in with me and the baby had moved. I'm like, oh, that just makes me look like a fool. But
I
hey,
it's normal.
but hey, when you get in a better position, it looked beautiful, right? And he's like, that's exactly what happened. The
Yeah,
baby was just in this funky position. And in the third trimester, even when, I'm doing a septal view in the third trimester, depending on how you cut that angle can
yeah.
really make it look bigger or smaller. So yeah, I
I
think,
There's one thing I think of in my head all the time is and I'm hoping I say this right, I can make an aortic arch look smaller than what it is, but I can't make it look bigger than what it is. And so if my biggest measurement is a small measurement, we got a hypoplastic arch going on. But of course, then when I'm measuring it, it's like, okay, I want to measure my biggest measurement and say that is the coarctation or the isthmus or wherever it is, whether it's transverse arch or whatever, versus like seeing the tiniest part, because that might be foreshortening it a little bit. And obviously it's easier to see things when the babies are out, but we also need to plan for delivery as well. And taking care of the baby immediately after birth. And so coarctations are hard. They are overcalled a lot. There's many cases here where we're like, get an echo within 24 hours of life, start a PIV, not umbilical lines, don't start prostaglandins. That duct is going to be open for a little while. Let's do 4-point blood pressures. Let's monitor this baby to see if a coarctation forms. But unfortunately, it's one of the things we get wrong more than we would like to admit, but we do.
yeah,
And we'd rather overcall it than not call it, right?
right, right, exactly, right.
And even we've had a case where right left heart discrepancy, we saw VSD. But then like the sonographer, she did a great job. She kind of what she thought was the arch, and then there was like this persistence of flow, like this continuation of flow. And it's like, that's a weird Doppler in the aortic arch. And so she went back and got way better pictures. And what looked like the normal arch in the sagittal view was actually part of her ductal arch, and her aortic arch was super duper tiny. And then she was able to narrow it in on the 3 vessel view, and it was, yeah, it was a great catch. Even like she showed the images to the doctor and was like, "What do you think about this persistent flow?" And the doctor's like, we got to check for coarc. We got to get better pictures." And so she sent her back. And yeah, like that could have easily been missed. So,
Yeah.
so yeah.
That's all. So is there anything else that, you're kind of like you're checking off your list, right? Your 4 chambers, your crux, your angle, your crux, your chamber size. What it was
Uh,
other thing
there,
that you mentioned?
yes. Oh, there's a lot of other things I look for with red flags. Like, don't get
Oh,
me
the
started. No.
septum dropout.
A septum dropout. So
Yeah.
yes, so that is so important. So when we're looking for VSDs, if the apex is up or down, you're not going to be able to rule out a VSD. The reason is we all know color flow needs to be parallel, and you're perpendicular when you're angling down and a VSD is going this way. So you need to be parallel to flow. So get that apex to one side or the other and sweep through, but you've got to have your box covering the entire septum, because I've seen apical VSDs miss because they don't cover that apex region. And I sweep literally through the entire heart multiple times. I'll take my radiant flow off and do it without radiant flow. I will do it with radiant flow. You also need to bring your scale down. And so bringing that scale down, because the pressures are equal on the right and left side. So you're not going to have like turbulent flow through a VSD. We also look for 2D dropout, but 2D dropout can trick you because you have ribs that like to shadow and other structures that will shadow and bones and all that good stuff. So, yep.
Yeah.
But arms and feet, I mean, I've had a foot up there. Like, I was like, you gotta be kidding me. And I've seen them like VSDs called, like large VSDs. And guess what? There's no VSD because you didn't see color flow and you didn't see it in 2 planes. You gotta see those in 2 planes.
So, Dawn, when we're talking about the VSD too, right? There's several layers to the septum, right?
Yeah, several different areas.
So it can also kind of be like a little bit of a Swiss cheese,
Yes,
right?
yeah. Swiss cheese is technically defined as 4 or more VSDs. I haven't seen Swiss cheese VSDs called on fetal echo, but I see them called on transthoracic echo. Usually on fetal echo, we'll say multiple ones. I mean, we're also looking at something that's pretty small. But yeah, you have your like perimembranous, your membranous, your muscular, like mid-muscular, and your apical regions as well. So there's a lot of different areas these little sneaky VSDs can be.
Yeah. And then sometimes I like to get the 2 ventricles on top of each other, right? And kind of scan it in
Yes,
a
absolutely.
process so that I'm making sure I'm scanning all the way through. So on the septal, your color box should be, I kind of make it more rectangular. So I make sure I include that apex.
Mhm.
The other thing you mentioned your scale to be low,
Mhm.
which I was taught as well. And the other day, one of the physicians I was working with was like, you need to increase your filter. And I'm like, oh, no, no, no. I don't do that on septal views.
Yeah,
I
I
can
know.
turn my
Sorry.
green down a bit, but I'm not going to increase my filter, right?
Mm.
So, what are your thoughts on that? Do you
Yeah,
have
no,
a
you have to bring your
filter?
scale down. Yeah, you got to bring it down because again, the pressures are equal. And so, yeah, I mean, I'm not going to bring it down like to the level I bring down to like my pulmonary veins, but I definitely bring it down, and I'll do like a 2D sweep to look for a dropout. I'll do a color sweep, and then I'll even do a color compare sometimes if I find a VSD so that you can reference it with the 2D dropout at the same time.
Right,
But
right.
yeah, I
So
mean, I
it's like,
always teach people to turn the color down.
well, turn the color down, but when
And,
she mentioned turning the filter up, that's not something I
mm,
typically mess with on the filter side of
mm.
that.
I don't mess with filter too much on that. I'll mess with filter on like my Doppler, my spectral Dopplers, but not necessarily on the color as much. So, I mean, but it also depends on like what machine you're on, how it's set up, what your settings are, all that stuff.
Absolutely.
Hmm. So yeah, size discrepancy, coarctation is a big one. Hypoplast, whether it's a hypoplastic right or hypoplastic left. There's lots of different versions of hypoplastic lefts. You can have mild, moderate, severe. hypoplasia, the ventricle. But the biggest thing, once we do say we have a hypoplastic left heart syndrome, is we need to make sure that atrial septum is open and it is not intact. If you have an intact atrial septum with a hypoplastic left heart, you better have the cath lab on standby when that baby's born, because they do not do well. And there's interventions they can do where they can try to put atrial stents in. You can go to certain facilities if it's a critical aortic stenosis that you don't want it to turn into a hypoplast. They can balloon the aortic valve. There's a couple institutions. There's a lot of institutions that do it. There's a couple that are more well known than others. The thing is, you can have a good hypoplast or you can have a bad hypoplast.
You can.
Whole spectrum there. And so, everyone wants to have a good hypoplast. So, yeah.
Funny that we can delineate that. Yeah.
Yeah.
So tell me about the circle of death, because I thought this
circle of death picture. I always think about like the ring of fire, but no, it's circle of death. So circle of death, bad news bears is what it is. So usually it'll happen with tricuspid, not usually, but it can happen with tricuspid valve dysplasia. I haven't seen it as much with severe Epstein's because but it can happen. So basically, the circle of death is when you have a really cruddy tricuspid valve. And so instead of having the flow go antegrade through the pulmonary valve, majority of it is regurging through. So now it's going back to the right atrium. Well, then as circulation goes, blood flow goes from the right atrium to the left atrium. So then it goes out the left atrium, through the left ventricle, out the aortic valve. But we have our ductal arch. The issue is the flow, because there's not enough flow going through the pulmonary to have antegrade flow through the ductal arch. You have retrograde flow. So that flow is now coming back from the aorta. It is going retrograde through the ductal arch. And therefore, you don't have antegrade flow in your pulmonary valve. You have pulmonary insufficiency. So then you have retrograde flow through the pulmonary valve, back through the tricuspid valve. Nothing's going really forward. It's mostly leaking. And that is your circle of death. And those kids come out really sick, like really, really sick. Not good sick. Their hearts are massive. Their CT ratios can be 0.7, 0.8. Like their right atrium that right side is so big, and it just is this horrible cycle. So yes, circle of death.
So paying attention to the blood flow and which way it's going and things like that, as well as structure, right? We're looking at function and structure.
Yes. We had a tricuspid valve dysplasia a couple days ago, and I was like, somebody had said circle of death, and the girl was like, what's circle of death? And I was like, oh, let me tell you about circle of death. And I said, do you have antegrade pulmonary flow? And I said, do you have pulmonary insufficiency? She said, no, but I don't see much antegrade flow. And the patient was like 25 weeks. I was like, we'll see it next time. We'll see the regurg next time and the retrograde flow on the duct. Just give it time. So it was interesting. It was kind of in that in-between stage. I mean, maybe it'll stay this way. Miracles happen. Who knows? It could maybe get worse, but I would expect this heart, because she's so early on in pregnancy, since there's no antegrade flow, to get reversal of flow and to end up in the circle of death. Well, obviously, we don't call it the circle of death to our families.
Right. Let's be clear, right?
That term is not used in counseling, but we do talk about that a little bit. How it's a very concerning factor to have all that reverse flow and just keep circle, and none of the flow goes out the aorta. It just circles in the heart. So you have very low output when the kids are born.
So the muscle doesn't contract and relax like it should.
Mm-hmm. Yep. So, yeah. What are the other things?
About the infamous tracks that cross, how your pulmonary crosses.
Yes.
When I was learning the fetal heart, this was like a huge deal.
Mm-hmm.
And it's still a huge deal, but I think we can I think what I was told at the time is that we can probably rule out 95% of heart disease if we can see that those two vessels cross.
I think the fair statement for that would be, if you gave me a 4-chamber sweep up through the heart, through a 3-vessel, all the way up to the 3-vessel trachea view, we could rule out 95% of heart disease.
Okay.
But I did,
right.
I had it up here. So there was a multi-center study, a fetal hearts society study that said like 58% of like transpositions were prenatally diagnosed. And the thing is those kids get really sick after they're born because you have two parallel circuits. And so in fetal development, the aorta and the pulmonary artery cross and they make an X. And in transposition, they're parallel. So you have two parallel circuits of flow. There was another article that talked about mortality of transposition, and in the subject matters that they had, the first year mortality in prenatal diagnosis was 0%, which is fair. As long as you have a good surgeon and the kid doesn't have multiple other things wrong with them, these kids do really well after surgery, and they're repaired within the first couple of days of life. The ones who were postnatally diagnosed, so they were born, they were a little cyanotic, got a little more cyanotic, went somewhere to have an echo, got flown or shipped to a hospital, day 2 or 3 of life, they're finally getting care, they're very, very sick, going into surgery, different story. And the mortality of that was 11.4% for postnatal diagnosis. So I think it's really, really important. Like you've got to show those crossing outflow tracks when these patients are born in Timbuktu or at home, they do not do well. They've got to be at a center because we need mixing at the atrial level. Like we have a PDA open when we're born, but we need more mixing than that. And so it's got to mix at the atrial level. So if you have just a little tiny PFO, it's not going to be enough. And we don't do surgery on day 1 of life, but within a couple hours of life, if they need more mixing to get their sats up above 60, we will do a septostomy in the cath lab and open up that atrial septum. And then when they go into surgically do their arterial switch on the heart, they'll patch the ASD closed. But that gets them to a couple days of life, which is important for the surgery. So, yeah.
So it makes a big deal. It makes a big difference.
Oh, it's a big deal. It's a real big deal. And also in your 3-vessel view, like normally our outflow tracks cross, but when they're parallel in our 3-vessel view, you don't get 3 vessels, you get 2 vessels because you're scanning in another plane. And so abnormal 3-vessel views it's why you got to refer. I mean, we get so many referrals for that, whether the aorta looks bigger than the pulmonary looks bigger than the aorta. You've got 2 vessels in a 3-vessel view. You've got 4 vessels in a 3-vessel view. You have all these different things. So that SCMS, I had done a slide at the end, I think, of all the different things. It was like of an abnormal 3-vessel detransposition, how different all of them look. So I love my 3-vessel view. I love my 3-vessel trachea view too. But yeah, it's really important. Those outflow tracks have got to cross because there's certain lesions that need to be repaired shortly within a couple of days or shortly after birth. And there's some that can, like a VSD, that's not going to get you into trouble right away. AV canal, not going to get you into trouble right away. TETs, usually not. Sometimes they misbehave and they're more of a blue TET. Even truncus, not going to get you in trouble right away. And so it's really important to get that transposition diagnosis. So, and I even showed a case study, and usually transposition is not genetic. Like left-sided obstructions can be genetic, hypoplastic coarct, bicuspid aortic valve, stuff like that. But this kid I showed, so the fetus had transposition, the dad's brother, so uncle of the fetus, was a repaired transposition they found at birth like 20 years ago. And then there was a grandfather that had passed away from what they assumed was transposition. I'm like, this is weird. We got to find some genetics on this. That's not normal. And they came in very well educated on transposition. Imagine that. So yeah. Outflow track's important. Another one I worry about is when the heart is too big in the thorax. So
something hard to tell, right? Because is the heart big and the chest small, or is the chest, which is
which? I would say a lot of times it's the heart's big, unless like that kid I had today, the fetus I had today that had dwarfism. That one you could definitely tell from the abdomen, then it went like concave down into the chest. Like Epstein's, tricuspid valve dysplasia, severe valve regurgitation, heart block can cause the heart to get bigger, like rhabdos, all these things can cause the heart to get bigger. And so when you have a CT ratio that's really high, yes,
Yeah.
one of the things you got to worry about. And another one is like a high output state. So absent ductus venosus, then we don't have that restriction of flow coming back. We have to monitor for output. Sacrococcygeal teratomas, same situation. We got a monitor for outputs on those. We had a fetus that it was weird. The heart was fine, but like had this lymphatic infiltrating thing going on all the way down to the leg. And I was like, is this an output situation? And it was like, we had to do outputs. And I even was like, I think I've scanned one of these before. And do I need to do outputs? Yeah, I need to do outputs. Okay. Got to do outputs. And so that's just, it's a calculation that we do. We have to get a really nice, well, parallel lined up, Doppler heart rate on that. We do a VTI on it, and then it goes into a fun little calculation package. And then we have to have the estimated fetal weight, which is what I get from my OB friends.
Right.
Accurate weight, because I'm not going to do it.
Right. That's awesome.
And then I think one of the, I talked about this, the twig sign.
The what sign?
The twig sign.
Oh, yes, yes.
Let's talk about that. So it was interesting because my, when I put this presentation together, there's not a book that says what the red flags are. So I phoned all my friends, right? And so all my sonographer friends were like, yeah, talk about the twig sign. And I had a physician friend say, no, that's not low enough hanging fruit. Like, stick with the crux, stick with the heart discrepancy, stick with the septum dropout. But, I wouldn't expect an OB sonographer to pick it up. And I'm like, challenge accepted. Like, why not educate these people? And if one of them goes back to their lab in the next year or 5 years and they see this sign and they refer the patient, that probably would have been missed. Like, my time was worth it spent up there. And so, the interesting thing with all of this is that was on a Saturday. On Tuesday, I'm back in the fetal lab and I have a 38-week patient referred for right heart discrepancy size. And I was like, does she have a coarctation? Nope. She got a tortuous ductus? Yep. We felt like the right heart was discrepant according to gestational age. It was appropriately larger than the left. And so I started to do my fetal echo and just kind of go through it. And the whole time I kept going, where are the veins? And I was like, I'll get them in a minute. Just keep going through. Then I go back and I'm like, where are the veins? And I'm like, I can't find these veins. Where are my veins? And then I started looking and I saw the twig sign. And I was like, she was 38 and 6. I was like, 37 and 5 still. I was like, you've got to be kidding me. And so the twig sign is basically when you look at your 4-chamber view of the heart, the aorta sits posterior to the left atrium. They should be in fairly close relationship to each other. When you have more space in between them, and if you have any form of a structure in between them, usually that is a sign of a pulmonary or of a venous confluence or a venous structure of some type. And so it looks like a twig. So you got your aorta in short, you got your heart, and then you've got this line in between that looks like a twig. And that's why it's called the twig sign. And the twig sign is representative of total anomalous pulmonary venous return of TAPVR. So like when I presented this in September, we didn't have any isolated cases of veins here. They are prenatally diagnosed, isolated, not heterotaxy. We're not talking about that. We're talking about a structurally normal heart that has total veins. It's only diagnosed 2 to 10% of the time prenatally. Like, that's it. And so this patient had a normal anatomy scan, got referred to MFM for gestational diabetes. They said the right heart was bigger than the left, rule out coarctation. So we ruled that out. That was fine. But during this exam, I'm like, these veins, this is not normal. And so I started doing more and I see this confluence and I follow it. It's important to follow it because you need to say, is this supracardiac? Is it infracardiac? If it's infracardiac, chances are good it's going to be obstructive. And so I looked at the SVC. It was not dilated. I was like, this is probably not supracardiac. And so I follow and I see this descending vertical vein going below the diaphragm, and there's obstructed flow down there. And so this patient was going to deliver at a hospital that had a neonatologist who takes home call. We changed that plan real quick.
Right.
They shipped to, or the she deliver at a, so we don't do, they're just starting a fetal center here. So the patient was delivering at another hospital. Our transport team was there at delivery and immediately swooped up the baby, brought him here. Within an hour of life, we were echoing the kid here, confirmed total veins. And those kids can remain stable for just a little bit of time. Like the kid was on CPAP and doing okay, but about 4 hours of life started to not do well. And we just ended up intubating just for safety. And within 12 hours of life, the baby had surgery. And 2 weeks later, the kid went home. And so it's amazing. Like when I gave this talk, I didn't think I was going to be the one finding it, right?
Right.
I mean, I think it's been at least a decade since I had isolated veins on a patient I scanned. Now we have a case here, but it's, the family, they went home at 2 weeks with a baby. Like that kid born wherever they were going to be born could have died, because the problem is they get so sick. And then the only way to relieve the sickness is to get rid of the obstruction surgically, but they're so sick. So see, these kids will come out on ECMO, they'll come out with their chests open. They do very not great. So knowing prenatally, it was very upsetting for the family, obviously. They were not going to be having their normal delivery and all of that. But they got to take their baby home. And so that's what matters in the end. And so this twig sign is huge. And I think if OB sonographers and MFM sonographers just look, like, even if you're wrong, just look for it. Like when I look at my 4 chambers, that's one of the things I look for. How far away is the aorta from the left atrium? And so we're writing up that case study right now to get submitted. So I'm in the process of that, just because I'm hoping that will help educate other sonographers. I was not expecting that.
Right.
And it could have easily been missed. There's times where you can't see veins very well, and you just say not well visualized or whatever. We always like try to Doppler a left and a right, but sometimes the angles you just can't get it. So it's like one pulmonary vein visualized. And if you have one pulmonary vein, you're not going to have total veins because you got one going back. And also the Doppler pattern on total veins is abnormal if it doesn't go to the heart. If it goes back to the heart, if it's a cardiac total veins, the Doppler pattern will be normal. But if it's like supracardiac or mixed or infracardiac, it is not a normal Doppler pattern. Normally we have a S, a D, and a little bit of an A wave. It's just kind of like a mound going over. Like there's no definition of that. And like I have seen us call total veins, not because we could actually see the veins, but because the vein Doppler was abnormal, like on a heterotaxy or whatever. So
Okay.
veins are hard. They're hard. But if we can have more sonographers when they're scanning, look for that sign, you could really make a difference in a kid's life.
And people's families, right?
Yeah. Right. Yes. Yes. So we, like I said, this baby got to go home. 2 weeks, went home. I was like, what? That's crazy.
Really?
The obstructed total veins are undiagnosed, and it is a well-organized, chaotic situation.
That's a good way to describe that.
Yeah, we all know what we need to do, but it's a little bit chaotic. And I've been called in for what they thought was a transposition because this kid's SATs were in the 60s. And I told the fellow, call me when the chopper lands, start scanning, because I figured they would need me for the septostomy. And so she called me, she's like, chopper's here. I was like, I'm on my way. It's like a middle of the night situation. And then she calls me as I'm driving. I'm like, yep, I'm on my way. That. And she's like, it's not a transposition. And I was like, what? And she's like, there's flow. And I was like, I'm on my way a little faster. So I get up there and she's like trying to show me. I'm like, girlfriend, just give me the probe. And I'm like, what is going on here? And around the PDA, there's all this flow. And I'm like, oh my gosh, the SVC was big. And I was like, it was an obstructed supracardiac total veins that was not diagnosed. And so what happened is the vertical vein, it gets compressed between the duct and the left pulmonary bronchus or left main bronchus, and it gets compressed. And so as I had just started to scan, my attending walked in and I was like, I didn't call you yet. He's like, nope, I was looking at home and decided to come in. And I was like, cool. So as I was scanning, he was drawing the picture because what had happened is the PDA went curly Q, and then went and got obstructed. And so there was all that flow. So it was really interesting. But that kid, okay, but was pretty sick. And because the baby that one was a big boy and he was blue, those three things actually go with transposition. So if you have a big baby, they're blue and they're a boy, a lot of times it's a transposition. And I think that's why they thought it was going to be a transposition because the stats were in the 60s.
Okay.
But the only thing that can fix obstructive veins is surgery. You can't give them prostaglandins. You can't put them on ECMO. Like if we crash somebody onto ECMO, especially a baby, we have to rule out total veins first.
Okay.
Because ECMO does not fix total veins, obstructed veins. So that is one of the things when a kid goes on ECMO, we are always like, are the veins normal? Even on an older kid. I really hope they don't have total veins as an older kid, but we still check the veins. It's important.
Yeah.
So yeah, it's nice when you see the surgery team walking out when you're going home.
Yeah. Right.
Bye, bye.
Amazing feeling though, right? Like you can go home and think, man, what I did mattered, right?
Absolutely.
What
Yep.
I did mattered. And so I hope as we discussed all these little red flags that we can look for and different things that we get so carried away and okay, do, let's get this done. And I hope we kind of slow down enough to just be able to say, man, what we do really matters. I matter. My education matters.
Yep.
Investing in yourself by listening to the podcast, by going to an SDMS conference, by reaching out to a friend,
Yep.
all these things matter, right? How you show up to work, it matters, right?
Yep.
So thanks for what you do. I mean, we as a team, I mean, I remember going to surgery even for other things, not heart related, but other things, and just thinking, man, those unsung heroes, and I don't mind being the unsung part. Like, I don't need to be like, front and center trying to get any attention or anything like that. That's not the purpose, but it's just like, I think it's important that we acknowledge ourselves, that we celebrate ourselves, and for the work that we do, because I think there's a lot of times we don't do that. And then that's when life becomes like the burnout, right?
Mm-hmm.
Burnout. And so thanks for what you do, because it does save lives. It does change families' lives. And, that's why I love going to surgery. And I tell, even now, I'm 54 now at the time of recording this, but when my friends tell me, oh my gosh, I got to go to surgery, I'm like, oh my God, let me tell you, when you're in surgery room, there's like 20 people, all eyes on you. Like, and when I start going into what people do in the surgery room, like everybody's ego drops at the door, right? Like, and I mean, it's just I love going to surgery because it's just a beautiful feeling of teamwork, of everybody has a part and everybody plays a part and everybody shows up and, amazing things happen. And so I think it's important that we acknowledge our part in it and celebrate it, and not that somebody has to throw you a big, huge party or anything, but that you yourself acknowledge you for your part. And, I always am whispering this little prayer, God help me, like even when I do routine scans, right? Because routine can become issues, right? And I don't want to miss something. I don't want to, I want to do my best. I want to show up as my best and be able to find these twigs and different things that really changed the course of people's lives, right?
Yeah. And it's not, when we show up, like, we have call and stuff like that. And I've had my fair share of call. And here it's really nice if you've been called in, you are not required to show up to work for 8 hours. So you can get some sleep, where before it was like, we'd still like you to show up at 8 a.m. So even if you're there half the night. And so I think it's important because here we emphasize mental wellness as well. As you don't think as well. I don't think as well now than I did 20 years ago. So it's
Right.
important to know your limits, but also, like you said, I think we perseverate on the bad things or something we did wrong, and it's the good things you do get brushed off. But I think it's important to remember to celebrate the good things and to celebrate the lives that you save. And if somebody sees a twig sign and you send them off and you were right, great. And if somebody sees a twig sign and they were wrong and the heart's normal, great. Like
Right.
these families would just rather have everything be checked and be told it's okay, or to deliver where you need to deliver to get your kid to live.
Yeah. And so, I think of the time when we weren't as anal about some of these heart
Right.
pictures.
Yeah,
and things.
absolutely.
I cringe at thinking that 28 years ago, when I was learning all this stuff, that I'm like, oh my God,
Well,
what
I
did
took one four
I?
chamber picture of the heart. That was it. That was what
Yeah,
I did.
yeah.
I still picture. And I was like,
That's almost embarrassing to say,
get it.
right?
But I mean, I was at a
yeah.
30-bed hospital. They barely did anything there. And I was just like, okay, this is fine. And then you go into pediatric echo and you're like, oh my gosh, what did I miss?
Well, and quite honestly, I'm trying to remember the name of the study, but I think there was a study that they did to see if doing all these heart imaging, heart extra imaging of the heart, of seeing the vessels cross. And we're talking about a simple 4-chamber LVO, RVO. Like we weren't talking about a 3-vessel or a 3-vessel trachea at the time. We were just talking about those 3 things.
Yep.
And how the study was like, well, it might not really be necessary, because so many were normal. And I'm thinking, oh my God, where is that study? Like, I want to see it, because that's certainly not my experience presently, right?
And 1% of the population has a congenital heart disease and a defect. Like congenital heart disease, it does not discriminate. It goes to whoever it wants to go. And, those parents are going to be handed the deck of cards that they are dealt. And it's the ones you don't think, or, you feel bad. The IVF ones, it's like, oh my gosh, you've been through so much and now you have a heart defect.
Right.
And it's not their fault. That's the thing. It's not anybody's fault. It's not because you ate some sushi. It doesn't discriminate, and it sucks.
Right.
Yes. But some are worse than others. And
thank you for what you do. Thanks for educating us and bringing this information to us.
You're welcome.
That we can learn and get better. And
Yes.
we hope to talk to you soon again on another topic.
Yes, I'd be happy to do another one.
That's awesome.
All right, cool. Well, thank you for your time. I appreciate you having me on again.
Oh, no problem. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.